Good morning, my name is Brendan. I am in the Chem 1005 class here at University of New England. I'll be going over two cases in the presentation for the case section Unit 4. I'll be going over both case 3 and case 4, and those are the cases that will be discussed. Here's this quick, and then we'll hop right into case number 3, because this should be a decently lengthy presentation here. For case number 3, we have a 47-year-old man who's admitted to the ER due to right great toe pain, causing him unable to bear weight on that right foot. Excuse me. Upon further investigation with a full physical exam and laboratory samples, the man received a gout diagnosis, actually, as we can see in the explanation for the question here. Then right below that, we can also see a chart. In this chart, there's a comparison between normal lab values and those collected from the patient. Obviously, normal on top, patient on the bottom. The patient has a high value of plasma urate at 10.5. Uric acid within the body is produced in the liver and is involved in purine metabolism as an end product. The patient, just like the plasma urate, is showing a lower value than what is normal for the urinary uric acid as well at 215, and that is compared to the normal value of 413 plus or minus 78 there. An overall lower output of urinary uric output shows the accumulation of uric acid within the body leading to gout. All right, next, what is gout itself? Gout obviously is a condition caused by hyperuricemia. As uric acid builds up in the body, uric acid crystals, monosodium urate, accumulates as purines are broken down in the body. Typical areas of accumulation are joints, as we can see in the patient. His big right toe is an area where he has experienced gout. Some of the symptoms are redness in the skin, pain, and swelling as well. All right, in the patient, there are three options to explain his gout presentation. We are going to look at the best explanation for the presentation of gout in this individual. Here, the first is the overproduction of purines. The second is decreased salvage of purines, and the last is decreased urinary excretion of uric acid. The best explanation for the presentation of gout in this patient is that last one right there that is not crossed out, decreased urinary excretion of uric acid. The patient has lowered urinary uric acid and higher plasma urate than normal values, kind of as we just went through on slide 1. This bill shows a buildup of monosodium urate in this patient is presented in the formation of gout. That third one there, decreased urinary excretion of uric acid, the data supports it that we went through, and not so much for the two options above would be affected. Okay, then again, that's kind of going over what we just went over. Decreased excretion, that urinary uric value, increased plasma urate, and the urate monohydrate crystals accumulation in that big toe on the right foot for that individual there. Okay, the patient has the urinary uric acid and higher plasma urate. Like I said, this shows a buildup in the monourate, as I said as well. And then we're going to move on to that next one and kind of talk about how it's not the other two. Excuse me. It's not an overproduction urates. Could have an effect through specific enzyme abnormalities, but there is a lack of testing for specific levels in the body that would point to a disturbance in the salvage pathway and production pathway. Sorry. The enzyme HPRT can be deficient in cases with overproduction of uric acid. HPRT is an enzyme that is part of the purine salvage pathway, and when deficient can cause overproduction of uric acid as the purine salvage pathway is inhibited. The HPRT enzyme itself prevents hypoxanthine and guanine from collecting and converting into uric acid, which causes gout inflammation, as obviously we can see in that patient's right toe. On this graph, we can see the mechanism HPRT kind of shown here. that enzyme, and it's described in what can happen when it's deficient. It's kind of depicted in this graph here. Another important part of the purine metabolism is the de novo purine synthase pathway in the enzyme PRPP aminotransferase. PRPP is used as a co-substrate with HPRT in the salvage synthase, ultimately from purine bases, hypoxine, and guanine, kind of as talked about above. The deficiency leads to the accumulation of these bases as discussed, and then the further accumulation of uric acid that is converted by xanthine oxidase. This scenario results in the purine overproduction and thus uric acid accumulation for gout presentation. There's no lab values that were given to us in this presentation that would point to this at all. It could be possible, but the overproduction of uric acid is seen in lab values and would explain the gout presentation and not that. Decreased salvage of purines would not lead to an increased uric acid accumulation in gout presentation as seen in this graph is uric acid as well. This value is also not seen in initial values given by the patient. This decrease in salvage of purines is not close to being correct, but the overproduction of purines, could be a possible thing to look at. Okay, and then what is the potential impact on this dietary modification of the presentation of gout? The patient has a diet high in fructose as he drinks more regular soda than obviously he should. A diet of 4 to 5 liters of soda a day causes that high purine diet, as fructose is high in those regular sodas. The study found, more so in the paper, that shows that fructose supply increases in the body and can lead to ATP use in fructose phosphorylation. This is in turn causes increased levels of ADP as a substrate for uric acid formation. Okay, now we're going to jump into case 4 here. In case 4, we have a 58-year-old patient who's admitted to the ER due to experiencing progressive fatigue and weakness. This patient is also experiencing many other symptoms like numbness and tingling of her lower extremities, loss of balance while walking, but she does deny neurological or cardiac symptoms as well. And obviously, she was taken into a physical exam. They kind of found some more worrisome, or had some other worrisome findings following that. And more of those worrisome findings kind of lead to a deficiency in B12 as the probable cause for the patient's presentation, as we'll get into in this next slide right here. So which of the following vitamin deficiencies is the probable cause for this presentation? As I said, vitamin B12 is that probable cause for the patient's presentation. This vitamin is necessary for the synthesis of DNA and combined with folic acid as the leading cause for metaloblastic anemia as well. Metaloblastic anemia is the accumulation of large broad cells in the bone marrow. The deficiency of B12 in the patient has a large impact on her health, as the vitamin is a cofactor that converts 5-methyl tetrahydrofolate back into tetrahydrofolate. Folate becomes trapped in the 5-methyl tetrahydrofolate and leads to the deficiency of methionine, and that is a essential amino acid. The patient experiencing vitamin B12 deficiency usually shows a loss of a vibratory sense, which, as we said, was one of her signs earlier. Our patient experiencing decreased sensation to physical touch and vibration in the lower extremities. A iron deficiency may be experienced in our patients as well, just not what I would say is the leading cause for the patient. Iron deficiency anemia is the result of an iron deficiency. Red blood cells will be at a reduced amount in an individual with the result of iron deficiency. Red blood cells will be at that reduced amount, and our patient will be showing signs of this as she has low hematocritic values. And she was referred to that hematology consultant as well. A vitamin B6 deficiency is a coenzyme that performs numerous functions. The B6 is associated with smaller red blood cells as well as other symptoms there too. Some of the symptoms an individual would experience is anemia, cracked skin, rashes, and swollen tongue. The patient is not experiencing signs that would lead to the diagnosis in B12 or B6 at all. A vitamin B12 deficiency also impairs purine and pyrimidine metabolism, as well as we'll look at this one right here. As stated in this prior slide, that methanolamine is an essential amino acid. The vitamin B12 is required for the synthesis of that amino acid. So by transferring that methanol group to the methyl tetrahydrofolate group, links the two pathways together, links that pathway with the purine and pyrimidine synthesis pathway as well. A vitamin B12 deficiency can lead to a reduced DTTP, and the deficiency decreases the amount of coenzymes 5,10 methylene tetrahydrofolate needed for that thymidylate synthase. Elongation of the newly initiated DNA fragments can be inhibited due to that vitamin B12 deficiency, which is the addition of that melanin CoA. Deficiency can prevent the gap filling that is required as the concentrations of the deoxyribonucleoside triphosphates is not at the required level it should be. And then finally, we do have some further tests that would differentiate the probable reason for this vitamin deficiency. The first test is that PBS test, which examines the individual's red blood cells, white blood cells, and platelets. This is a very hands-on test as healthcare providers are looking at the abnormalities to get further answers through a microscope. Further information can be received in a PBS test too. Another test that would be valuable to us would be a CBC test, which is a complete blood cell test, which would determine many different types of conditions such as anemia, infection, and leukemia. This test can be This test can determine the amount of red blood cells, white blood cells, hemoglobin, hemocritic, and platelets. Possible medical conditions come to light with these CBC tests. The diagnosis of vitamin B12 deficiency can be done with the CBC test, and if you're not looking at that, you can get just a straight up vitamin B12 test too, to determine if the patient does have that vitamin B12 deficiency. A final test that can be valuable for both the patient and healthcare providers to determine exactly what is the patient's diagnosis is that bone marrow biopsy and aspiration test. This is done to just examine that bone marrow and whether that bone marrow is healthy and producing the normal amounts of bone marrow should. An accumulation of these tests can show more concrete results leading to the diagnosis of the patient. Then finally, I listed all my resources there, or references that I used for this presentation. I know this one is a little long, and I appreciate you guys sticking with me. Again, thank you.